Good evening, everyone. I'm going to start with Vitreous Haemorrhage from Namrata Sharma. But if you want to have a better understanding, first go through the video on Vitreous Haemorrhage that is present on the channel Inside Ophthalmology. That is one of my favorite channels, my most favorite channel on ophthalmology these days. So you can go through that thing. It is almost 30 to 40 minutes of video on Vitreous Haemorrhage, and then you can be back to this video if you have time. It will take 1.5 to 2 hours. So we'll start a long case, vitreous haemorrhage. Introduction. Vitreous haemorrhage is defined as the presence of extravasated blood within the space outlined by the internal limiting membrane of the retina posteriorly and laterally. The non-pigmented epithelium of the ciliary body laterally and the lens zonular fibers and posterior lens capsule anteriorly. So it's defining the borders of the vitreous cavity into which the vitreous haemorrhage occurs. So laterally, posteriorly it's retina, anterolaterally it is non-pigmented epithelium of the ciliary body, and anteriorly it is the posterior lens capsule and the lens zonular fibers. The incidence of vitreous haemorrhage is 7 cases per 1 lakh people or population, which makes it one of the most common causes of acutely or subacutely decreased vision. Such cases are a common reason for surgery and a favorite for long case. During workup, focus should be on identifying the cause of vitreous haemorrhage. History. The chief complaint. The symptoms of vitreous haemorrhage are varied but usually include early or mild hemorrhage cases present with floaters, which patient describes as cobwebs. Cobwebs means spider web. Ring shadow, multiple insects moving in front of the eye, smoke signals, dark clouds, or even red hue. In severe cases, sudden onset of painless loss of vision, unilateral, is the usual complaint. That is the most common presentation. So, causes of sudden painless loss of vision, unilateral, it can be amaurosis fugax, retinal detachment, retinal artery occlusion, and this vitreous haemorrhage. It can be AIO in giant cell arteritis, polyarteritis nodosa, systemic lupus erythematosus. These are the other causes, rare causes. Now, hemorrhage that is more significant can cause visual field defects or scotomas. Scotomas means it is the area of decreased vision surrounded by the area of the normal vision. History of present illness. Presentation can be unilateral or bilateral. It may be rapidly progressive. Preceding events such as trauma, valsalva manual, recent surgery, or recent retinal laser therapy must be recorded. Many a times, the patient would give a history suggestive of the cause of vitreous haemorrhage, for example, recurrent pain and redness suggestive of uveitis, or visual field loss suggestive of retinal venous occlusion. Glaucoma or central scotoma in age-related macular degeneration. Scotomas remain fixed in the field, whereas generally floaters move with the eye movement. Preceding events, very important, that gives the idea about the cause of the vitreous haemorrhage. So whether there was any trauma. And then valsalva manual. What is valsalva manual? Valsalva manual means it causes increase in the intraocular pressure. Means you just close your nose and mouth, and then you hold your breath for 15 to 20 seconds and you strain as if you want to poop, and that causes increase in the intraocular pressure, valsalva manual, and that can lead to the vitreous haemorrhage. Then, especially in case of the neovascularization or microaneurysms, in such cases, vitreous haemorrhage can occur. Then, recent surgery or recent retinal laser therapy must be recorded. Many a times, a patient would give history suggestive of the cause of the vitreous haemorrhage, that is recurrent pain and redness, suggestive of uveitis. Uveitis, it can cause the vasculitis, for example, sarcoidosis, Behçet's disease. Sarcoidosis, it is autoimmune disorder. You can say it is autoimmune disorder which involves multiple systems. There are granuloma formations which are non-cageating granulomas. It involves lungs and eye, brain, other visceral organs. Joints, kidneys. Uh, so uveitis and basis, this is orogenital also. Pathogitaste means you just scratch the skin with a needle and then there are papules and pustule formations in 48 hours. That is positive pathogitaste in the basis disease. So these are the causes of the uveitis that can cause the vasculitis and that can lead to the bleeding, vitreous hemorrhage. Visual field loss suggestive of retinal venous occlusion. Retinal venous occlusion, usually the cause is neovascularization. Um, so retinal venous occlusion, especially branch retinal venous occlusion, that is more likely to give rise to neovascularization. Central retinal venous occlusion, it gives rise to NVI, NVA, and less commonly NVE or NVD. Age-related macular degeneration, weight ARMDs can cause this CNVM. They can lead to subretinal bleeds which break into the vitreous, causing the vitreous hemorrhage. And scotomas and floater difference is very basic. Scotomas don't move in the visual field, and the floaters, they move with the eye movement. History of the past illness, history of trauma, diabetes, hypertension, tumors, hemangioma, retinoblastoma, melanoma, retinal angioma, Valsalva-Manua, shaken baby syndrome. Shaken baby syndrome means you are vigorously shaking the baby's head. That leads to subarachnoid hemorrhage, subdural hematoma. It can even cause death. So that is shaken baby syndrome, and that subarachnoid hemorrhage can seep down with optic nausea and then can lead to the hemorrhage in the vitreous. Venous occlusion, bleeding disorders. Bleeding disorders, these are hemophilias, acquired and genetic bleeding disorders. If you want to know the bleeding disorders and hypercoagulable states, I'm going to share certain videos which are of 10 minutes only. You can go through that. It will be a rapid revision of bleeding disorders and hypercoagulable states. It will take 20 minutes more. So if you want to learn nicely about bleeding disorders, hemophilia A, B, C, or the coagulation cascade. In short, it's very nicely given. Primary hemostasis, that is platelet block formation. Secondary hemostasis, that is coagulation. Then there is intrinsic and extrinsic pathway in coagulation, and how to measure that bleeding time for platelets, and then prothrombin time, activated partial thromboplastin time for these coagulation cascade, coagulation time. So bleeding disorders, hemophilia, genetic hemophilia A, factor 8 deficiency, factor 9 defect is B, and factor 11 defect is hemophilia C. And then these are the genetic causes. Then there are different acquired causes. There are different innumerable acquired causes causing platelet deficiency. Many. And even other clotting factor defects. Then leukemia, ocular surgery, glaucoma surgery, retinal detachment surgery, iatrogenic causes, cataract surgery, surgeries, glaucoma, retinal detachment, cataract, laser, panretinal photocoagulation, vasculitis, chest compression, pseudotumor cerebri must be asked as it may provide a clue to the underlying cause. Recurrent vitreous hemorrhage may point towards the Eales disease and proliferative diabetic retinopathy or bleeding diathesis. Recurrent vitreous hemorrhage causes, if it is a young patient, then it is Eales disease, as we have already discussed about it from the Rhine's retina. Then another, if it is type 1 diabetes mellitus, younger patients, and if it is type 2 diabetes mellitus, older patients, that is the recurrent cause of the vitreous hemorrhage. And another cause is bleeding diathesis. The bleeding diathesis from very young age. History from the fellow eye may also be suggestive of ocular predisposition to VH, obviously diabetes, hypertension, bilateral causes, bilateral uveitis causes. In cases of trauma, it is necessary to classify as per BETTS. To prognosticate, as such cases can often be medico-legal. Family history of diabetes, hypertension, bleeding disorders, leukemia, tumor, vasculitis must be recorded. Family history of diabetes, then hypertension, bleeding disorders, leukemia, tumor, vasculitis. Even you can ask for the glaucoma. Past surgical history, a detailed past ocular surgery must be noted. For example, retinal detachment, cataract, and past medical history, laser photocoagulation, medical history of diabetes mellitus, systemic hypertension, drug intake, sickle cell diseases, anemia, bleeding diathesis, and cerebral stroke can give a valuable clue even before ocular examination. Medical history of even the conditions like warfarin treatment, heparin treatment. This medical history is also very important, which lead to the increase in the bleeding, clotting time, INR. So that was about the introduction and history. Now examination part we'll see in the next part.